All right, so we'll get started with our cases here. Again, as yesterday, we do have 2 microphones, and we invite audience participation. We'll be doing a couple of surgical and interventional cases. The first is a hybrid approach to coarctation of the aorta. This was a 46-year-old woman with coarctation of the aorta, a ventricular septal defect, and bicuspid aortic valve. She had a coarctation repair at the age of 14 months, and in 1972 had a cardiac catheterization. At that time, her VSD had spontaneously closed. There was a 50 millimeters of mercury gradient across the coarctation, and she had no aortic stenosis. But unfortunately, this procedure was complicated by a brachial artery occlusion. In 1973, she was reoperated for coarctation. And in 2001, due to symptoms of exertional dyspnea, she was found to have severe bicuspid aortic stenosis, and the following year underwent aortic valve replacement with a 22 millimeter homograft. That was complicated by postoperative third-degree heart block, and she had a pacemaker placed. And now she's being referred by her local cardiologist for a residual coarctation gradient of 36 millimeters of mercury by echo, and she has complaints of exertional dyspnea. So this is her echo, and you can see here on her parasternal long axis view that she has good left ventricular function. There's some left ventricular hypertrophy. You can see her bioprosthesis here in the aortic position. We've now placed color Doppler across that valve, and you can see that there's no significant flow acceleration across the valve, but there's mild aortic regurgitation. Short axis view again shows good left ventricular function with some LVH. And now we're in a suprasternal notch view, and you can see that there's some flow acceleration here. You don't really see it too well. But when we apply continuous wave Doppler, we can see that there's a 36 millimeters mercury gradient. So at this point, in the interest of time, I'm just going to save the questions for a minute. We performed an angiogram, and you can see here that there's a significant coarctation at the site of prior repair. We then obtained hemodynamics, and her left ventricular systolic pressure was 140 over 20 millimeters of mercury. The ascending aorta had a pressure of 140 over 60, mean of 92. Descending aorta was 105 over 55 with a mean of 75, giving us a gradient of 35 millimeters of mercury. So at this point, we had a significant gradient with symptoms, so we had planned to go forward with a coarctation repair percutaneously with stenting, and on our way out, we performed this angiogram of her left common femoral artery, and this is what we found. You can see here that our sheath is in the left common femoral, and it's nearly occlusive. She has a very small artery up here. And so at this point, I'd like to ask our panel to weigh in here. What are our options at this point?
I mean, the first question I guess I would have is the coarctation repairs, were they done with patches, or were they done just resection of tissue and tissue to tissue? Or?
I believe it was an end-to-end anastomosis.
The only reason I ask is because I mean, there is always concern sometimes if there's a lot of the diameter that's a patch. If you just stretch it open with a balloon, there is a potential for disruption or the patches coming off. In cases like this, what we've done in the past is to coordinate with either vascular surgery or cardiothoracic surgeon to give us access. Sometimes through, they can put a graft onto the vessels, the iliacs, for example, and give us access through that approach. Or sometimes you can use the surgical access from above, from a brachial artery. And do your angioplasty or stent placement using that approach.
And just to clarify for our audience, the reason for that is because basically this vessel is too small for our delivery system. So again, she had a recurrent coarctation. The focal narrowing was 8 by 7 millimeters. And again, she had that very small left common femoral artery, which was essentially nearly occluded by our 8 French sheath. We did an angiogram at the end. There was no occlusion after removing the sheath. And so we proceeded to go ahead with a hybrid procedure with a right subclavian cut down performed by Dr. Reemson from cardiothoracic surgery for access. So our angiogram on the left, we are here about to, we've positioned our stent. You can see the significant coarctation after the left subclavian artery. You can see our axis is from the neck here. And now we've gone up with our stent here. And looks fairly good. And now we've taken an angiogram after we've placed the stent. And if you look closely, you'll see that there's some extravasation of contrast here, a small aneurysm. And we waited for a few minutes, and then we took another angiogram, and you can see here that this is getting bigger. And so now I'd like to ask our panelists again, at this point, what are our options in terms of percutaneous options versus sending this person to surgery?
Well, obviously, you'd like to use a cover stent if you could. In Europe, they could do it immediately off the shelf. Here in the United States, you could have your surgeon construct one for you and put it through a large sheath and sort of do a similar procedure, or of course you could do surgery. I just wondered, is the other femoral artery open or not?
So actually, the right femoral artery, there was no pulse and couldn't see it by ultrasound. So the left was all we had.
Okay, all right.
And then there was one other thing for you. If you don't mind just going back one slide to the delivery. So if you see the delivery there, the second angiogram there, this was delivered on a balloon, and you'll see that there was a residual waste there that was about, I believe, 12 millimeters. So we then inflated with a really high pressure Atlas balloon, which is what poured the aorta. So it was really that the enemy of okay is good in this particular case.
Can you put a core matrix on? Can you make that coverage stent by putting core matrix?
You probably could.
We've actually done that. In one patient, the only trouble we had was getting it through a 12 sheath. But if you, even the Cheatham stents go through 12 or 14 sheaths. So it's a little thicker than the one that's made commercially available, but you could if you use the 14 sheath. So it's clearly doable. We just played with it in vitro once, and we tried to do it in a patient. It just wouldn't go to a 12 sheath. We felt uncomfortable using a larger one, but it's a very good concept, actually.
The only problem with that is you're not sewing it to anything. And like I said, in the cases where you haven't sewed it, just put in there. It's the viability of that is unclear.
Or you would sew it to the stent.
To the stent.
Right, but to tissue is what I'm saying. Is if you're not sewing it to tissue, it's not clear. So I mean, if you could, I feel more comfortable just, especially in this size patient, putting a Gore-Tex. I mean, I would try to make one of those first, probably.
So,
I have a covered stent in your cath lab. It's called a melody valve.
yeah.
Take the melody valve out and put it in there and close off the end.
That's pretty much what we did. So yes, that's exactly what happened. So essentially how'd you know? But basically we were in a situation where we didn't have a covered stent, but we did have a melody valve. So we decided to use a melody valve as a covered stent, which is what it is. We did, Dr. Reemson did remove the valve leaflet with scissors, and we went ahead and put it in. You can see that this, we've positioned it to cover that aneurysm, and now it's going up. This is, we've gone up with the, there we go. It's inflated here, and now you can see the, afterwards, it still looks good. And I think we've got one more angio. Oh, nope, we don't. Sorry.
All right, thank you very much. So let's move on to the next case. But you'll notice a theme from yesterday that I often pick patients that have kind of gotten lost to follow-up. So this is a 61-year-old gentleman who had a coarctation repair when he was 34 years of age. He had no follow-up since about 1 year after the procedure. Again, he fell into that category of people that thought he had a surgery and he was now cured. He was having escalating doses of antihypertensives by his primary care physician. He was having frequent ER visits for high blood pressure and headache. Again, this also demonstrates that when this patient came to us, that that good old clinical medicine can be really valuable, because his initial blood pressures were all in the left arm, and they thought he was normotensive and thinking that he was having a stroke. He was subsequently found to have a high blood pressure in his right upper extremity of 215 over 130. His left arm blood pressure was 80 over 40, and his lower extremity blood pressures were not taken. This was his chest x-ray, so I'd just like to turn to the panel to see if they have any thoughts or opinions about the chest x-ray, just starting for good old clinical medicine here.
You got a very prominent aortic knob.
Exactly. So we see a very prominent aortic knob right here, and we subsequently were able to get a MRI of this patient, which demonstrated a very profound recoarctation and aneurysm distal to the side of coarctation. So at this point, we sent the patient for surgical consultation, and the patient was discussed some different alternatives, and Dr. Reemson actually had some good thoughts, and I just wanted to give that to you to maybe discuss some of the alternatives to an open thoracotomy for this type of procedure.
Yeah, obviously it's a very morbid procedure, and it requires circulatory arrest, albeit short circulatory arrest, if you can try to avoid that. So I discussed with the vascular surgeons their ability to place a stent and cover essentially the subclavian artery that you can see there. And before the stent would be placed, they could do a carotid subclavian bypass, and then place a stent over that area after ballooning the recoarctation.
So that's exactly what we did. We actually referred the patient to vascular surgery. He had a lot of discussions with Dr. Quinones from vascular surgery, as well as with us. And ultimately, they were a little bit hesitant because they were concerned that they wanted to go non-invasively, but they were also concerned that the lack of exposure and actual correction of the defect would be achieved. So he ultimately ended up deciding to have the less invasive approach with vascular surgery. Here's a picture of the first injection, and the ascending aorta pressure was 121 over 52, and distal to the coarctation was 100 over 50. You can also see up here that the carotid subclavian bypass has already been performed, and then I'm going to show you a moving image of this. During one of our discussion conferences on a similar patient, Dr. Lax, you discussed a concern that you had in terms of the carotid now supplying blood supply to the left arm. Can you elaborate on sort of the still phenomenon to the brain in these situations?
Well, the concern would be if you left a communication distal to the obstruction down to the descending aorta, so that you could get a steal from the carotid to the subclavian. For most of the carc patients, because they've developed a lot of collaterals, probably a steal is unlikely, but it is something that one has to consider.
So I think the patient was told that there was about a 1% chance of having insufficiency to his brain. So here's actually a moving image that is a little bit long, but we show some digital subtraction techniques and the deployment of a PTFE stent, which I'll show you in a second. Unfortunately, you see here that a more compliant balloon was unable to actually hold open the obstruction. So then Dr. Abelholz and I were called to the room, and Dr. Abelholz then subsequently deployed a more rigid stent, a Palmas Genesis stent, and using a Z-Med balloon to be able to stent it open. And there's the final result.
So that was rapid pacing?
No, this is just reducing the frame rate. Otherwise, it would have been about a 5-minute video.
So you don't have to rapid pace when you put a balloon up in the aorta like that?
So I'll defer to my interventional colleagues.
Place the stent.
Right. And oftentimes we use a bib balloon, so you position it and then you have time. Usually you can do it without.
Also, coarctation, or this is a stenosis after the repair? That's in the transverse aorta.
This probably was a very hypoplastic arch, and it looks like they probably patched the distal portion of the aorta and opened that up. But, you know, that as the baby grew, as the child grew, that portion of the arch just didn't grow and continue to be really stenosed, or at least that's what.
Yeah, that was our understanding. Yeah, we believe he had a patch repair of some sort, so, you know, but there may have been tissue that wasn't fully addressed because it may have extended too close to the subclavian artery at that time. So here's just some still images. I was afraid my video wasn't going to work. Here's a picture of the graft that was used in the aorta, but the issue that we ran into was just too compliant for the recoarctation area. So after deploying the endovascular CTAC graft and the pulmonous genesis stent, the pressures on both sides of the prior obstruction were equal. The patient is now on single-agent therapy for his hypertension, and he's doing great. One of the interesting things, and I think we've seen it a few times over the past year, is that a lot of our patients have some vocal cord issues after surgical intervention for congenital heart disease. And this patient actually had about 2 to 3 months of sort of very soft voice and hoarseness. Given the carotid subclavian bypass, we were concerned that there may have been some sort of nerve injury, but he ended up successfully recovering his entire voice. But, you know, is there anything that we can think of in terms of quality improvement to really be, you know, aware of these types of issues in our patients?
You know, as far as the voice issue is concerned, it could have occurred in the neck or with the dilatation of the aorta. Mm-hmm. And the fact that it recovered would suggest a stretching injury. Certainly, you know, compared to surgery, the chance of injuring it with surgery is extremely high because you have to go across that whole area and expose it and dissect it. So a large number of surgical patients would have a permanent recurrent laryngeal nerve injury.
Great. So we'll move on to our third case, and we're doing pretty well with time.
All right. The next patient is a cyanotic woman with severe exertional dyspnea. So this was a 49-year-old woman with complex cyanotic congenital heart disease. I don't usually say that, but she's quite complex. Detransposition of the great arteries, a ventricular septal defect, pulmonary stenosis, a prima mitral septal defect, total anomalous pulmonary veins, and a persistent left SVC to the coronary sinus. So she had a repair at age 9 with the IVC and SVC baffled to the mitral valve. The VSD was closed, and she had a pulmonary valvotomy. At the age of 10, she was cathed, and that showed a residual VSD with bidirectional shunting, severe pulmonary stenosis, and a large pulmonary artery aneurysm. At that time, it was around 5 centimeters, as well as some degree of pulmonary hypertension. And she's been plagued by arrhythmias, atrial fibrillation, atrial flutter, and non-sustained ventricular tachycardia. So this is a really nice diagram by Dr. Abelhausen. Quite impressive. I just want to kind of show you her anatomy. You can see here that she has total anomalous pulmonary veins, and that actually was appropriate for her because these are going to the right ventricle, which is a systemic right ventricle, so it's hooked up to the aorta. And then the surgeons, when she was a child, took the inferior and superior vena cava and directed them to her mitral valve and into her subpulmonic left ventricle. She has severe pulmonary valve stenosis here, and the residual VSD, so she's shunting the blue blood across the VSD into the systemic circulation, and then she had a large aneurysm, and over time, in the last 6 years, it had grown to a dimension of 11 centimeters. And so she came to us because of her symptoms. She had this dilated main PA, it was now 11 centimeters. She had suffered from sequelae of cyanosis, including hemoptysis, epistaxis, and thrombocytopenia. She had been referred to another center for a heart-lung transplant, but was turned down due to concern for liver cirrhosis. I should mention that she did have a liver biopsy that showed fibrosis, but no cirrhosis. And she was very, very symptomatic. She'd had worsening exercise tolerance and cyanosis. This was a woman who could previously do her activities of daily living. She could go grocery shopping, and now she could no longer even do anything at home. And she came to us for a second opinion. So I'd like to ask the panel as well as the audience, what are our options at this point for this woman? She's clearly very high risk for surgery. She's very cyanotic, but she's extremely symptomatic. I first have an echo, and this is unfortunately not the prettiest echo. You can see her subpulmonic left ventricle here has reasonable function. Here's sort of a suggestion of some turbulence here. You can see here that her great arteries are parallel, and her aorta is anterior, pulmonary artery is posterior. Again, there's some flow acceleration here in her pulmonary artery, across the pulmonary valve. We didn't really get a good view of that on echo, but the gradient was around 80 on echo. And you can see here that she has this tiny, tiny residual VSD. So she did actually undergo catheterization, and I know this is a very confusing diagram, but I think what's important here is to look at her subpulmonic LV. It has a pressure of 180/20, and then here's her pulmonary valve stenosis, and beyond the stenosis, her pressure is 100/40 with a mean of 54. So at rest, she has a gradient of 80 millimeters of mercury, which is what it was on echo. Her systemic RV has a pressure of 100/15, and then her systemic saturation was 76%. We then did some calculations. Her QP to QS at rest was 0.5:1 with a PVR of 20 Wood units, so very high. We then gave her nitric oxide of 40 parts per million. We often do this in the cath lab. We do a nitric oxide challenge to look for vasoreactivity. And with that, you can see that her gradient across the pulmonary valve was still elevated as it went 180 to 80, so 100 millimeters of mercury. Saturation was about the same, but her PA pressure came down from 100/40, mean of 54, to 85/30, with mean of 48. And her QP to QS is essentially the same, 0.6:1, with a PVR of 16 Wood units. So I'll ask our surgeons, this person, what would you estimate her risk to be if she went to surgery?
Risk of what?
Her risk of death, her risk of cardiovascular, morbidity, mortality. Do you think that this?
You mean you don't see this very often, but I've seen someone undergoing a complex surgery like this with a 20 Woods unit, so I'd say it's in the 90s. And just the fact that she has liver cirrhosis and things of that sort as well, she doesn't seem like she's an appropriate surgical candidate.
Yeah.
I just want to add that she actually originally came to UCLA. She'd been evaluated at Stanford for heart-lung transplant, turned down, sent to UCLA for consideration of heart-lung transplant, and also turned down here because of just the complexity of her anatomy, concerns over her liver disease. So it was basically consider something or hospice care, and that was what the discussion was.
And I guess just to take a poll, how many of you in the audience would just do hospice for her? She's very limited. No one? It's an option.
Well, one thing is that you could use pulmonary vasodilators, right? I mean, chronic medications for... You have PA hypertension and PS are your main problems. I'm sorry, I couldn't read the wedge. There's no pulmonary venous obstruction.
There was no pulmonary venous obstruction.
Pulmonary venous pathway obstruction?
No, we don't have a pulmonary vein saturation.
Yeah.
We had an MRI as well.
And low, right. So occasionally you have obstruction there. So, yeah, so...
But one consideration here that outside of just the treatment of her limitations is she had gone from having a 5-centimeter pulmonary artery to 11 centimeters.
Right.
And the risk of PA rupture was one of the worries.
Sure.
With a hypertensive PA.
Which, I think this ballooning for pulmonary valve and closing the VSD may alleviate some of the cyanosis and LV pressure overload, but frankly, I don't think that would do too much for the PA aneurysm.
But actually, it'd be nice to have a pop-off. Actually, this would be a pop-off for pulmonary hypertension, the VSD. So it's actually good to have a little pop-off. It's like in the reverse condition when we have a right-to-left shunt and you have severe pulmonary hypertensive crises. So, but the aneurysm is the main problem.
The other thing is that VSD was actually very, very small, so we didn't really think it was significantly contributing to her issues. So we talked about all of these issues. One was to do supportive care only, but the main issue was really that very large PA aneurysm, which we felt was at high risk for rupture due to the pressure of in the 80s and that PA. Again, we kind of discussed heart versus heart-lung transplant, and she was declined due to her many comorbidities and palliative surgery. And ultimately, following extensive discussion, we did proceed with palliative surgery. And this is what we did. I'm sorry, this slide got... Dr. Lex performed the surgery, and she was placed on cardiopulmonary bypass. He first opened and resected the aneurysm, and then the pulmonary valve with subpulmonary stenosis was resected. And then at this point, I'd like to ask Dr. Lax to kind of fill us in on the thought process in terms of what happened next with the pulmonary valve.
Yeah, in order to shorten the procedure as much as possible, I think Dan came to the operating room. We put in a Melody valve in situ, which was very quick and perfectly positioned and really shortened the procedure significantly. And the aneurysm, as you heard, was excluded by making a distal anastomosis after tailoring the bifurcation, and then a single graft to completely exclude the aneurysm. And I must say that we're thinking of doing some other cases in the systemic valve with a similar thing of doing a sort of hybrid in terms of placing a Melody in the aortic position or truncal valve position as well, just in terms of shortening and simplifying the procedure.
So Dr. Lax, what did you use as the place for the Melody valve to position or be seated? Because the valve that was heavily calcified was resected, right?
Right. One can resect as much as one needs in order to seat that 18 millimeter valve. And it was actually positioned by direct visualization. So it would straddle the area of the valve.
And so you can see her cardiopulmonary bypass time was 175 minutes and a cross-clamp time of 129. She came off bypass with an oxygen saturation of 97% on 50% FiO2. The VSD was left open for the reason that we kind of discussed, wanting her to have a pop-off valve and also just not feeling that it was a very large VSD. She self-extubated later that night, which is always a good sign. She was discharged from the ICU on post-op day 5, went home on post-op day 14. I should mention that we had started some pulmonary vasodilators prior to the surgery, and we continued those. We gave her sildenafil, continued her diuretics, and her saturation and discharge was around 93% on room air, and her functional capacity improved from class 4 to class 2. We've seen her 6 months post-op and added trachlear, and at our last follow-up visit, she's doing extremely well. She's now pink and back to participating in her activities. It's really great.
Nice. You have an MR jet velocity? You have an estimation of PA pressure? At follow-up?
I don't recall what it was, but intraoperatively, after we put the Melody valve, the gradient across the valve between the LV and the PA was about a peak of 20,
right.
Transesophageal echo. Actually, the way the valve was positioned was it partially covered that VSD, and which is why our stats also improved significantly. There's still a little touch of flow across it, but really not very much at all. So, but she still has severe pulmonary hypertension.
Right.
It's just not as blue now, and the aneurysm's been taken care of. And the performance of the Melody valve, 6 months post-op, or I believe the last time we looked at it was about 4 months post-op. It's pretty good. I was very worried about the degree of PR because these valves are used in a low pressure circulation, typically, or low pressure circulation, and that has not. She does not have the mild PR at this point. So we'll see what happens with that.
Did you use anything to reinforce the aneurysm, the PA?
The aneurysm was treated by excluding it So we had a distal anastomosis to the bifurcation and a proximal anastomosis to the sinotubular junction of the pulmonary valve or pulmonary artery, and with the melody valve just below that.
All right, great. Again, everybody's invited to come up and ask questions of the panel. We've been kind of running through the cases pretty quickly, but we have a couple more for you. The next one we've called affectionately subaortic stenosis with a twist. So this is a 42-year-old woman who was noted to have a childhood murmur. She subsequently had a mitral valve regurgitation, underwent a mitral valve replacement as a college student. Approximately 10 years later, she noted some exertional dyspnea and lightheadedness and was found to have subaortic stenosis. She underwent a subaortic membrane resection, and at that time, that was approximately about 10 years prior to her presentation. And then about a year ago, she was referred back to UCLA for exertional symptoms and recurrent LVOT obstruction by echocardiogram. Her cath showed that her LV pressure was 180/22. In the ascending aorta, the pressure was 140/80, which gave a 40 millimeter peak-to-peak gradient across the outflow tract and across the aortic valve. There was no significant mechanical mitral valve stenosis by a simultaneous wedge pressure and assessing the LV EDP at the same time. So here's her angios. And I'll let my interventionalist sort of discuss with you what they're seeing in this picture. Not to put you on the spot, sorry.
We'll call it our adult colleagues.
So the interesting thing here is that the right coronary artery actually arises from the LAD and crosses the aortic valve. So here are some still pictures of this. You can actually see right here how the artery sort of crosses the left ventricular outflow tract. So the patient was noted, as I mentioned, to have this artery coming off the LAD. So the patient was discussed at our surgical discussion conference, and the Kono-Rastan was considered to be a very high-risk procedure because it would include ligating the right coronary artery and doing a bypass graft to the RCA. So I'll throw it out to the panel to sort of discuss other possible techniques for this patient to address her obstruction.
The nature of the subaortic stenosis, it was a recurrence of a subaortic membrane?
So yes, it was a recurrence of a subaortic membrane, and also just the LVOT was felt to be small. Unfortunately, I don't. We were trying to cut it down a little bit in terms of our leg.
So basically, you're looking for an alternative to left ventricular outflow that doesn't require transecting the right coronary artery?
Correct.
I mean, from a surgical standpoint, would you consider LV apex to? I know we don't dislike that surgery, but LV apex to descending aortic conduit?
It depends on the nature of the stenosis. If it's a tunnel stenosis in the left ventricular outflow tract, if it's just at the valve or just in the subvalve, you can do where you can open up the LVOT posteriorly into the mitral valve. But if this is a tunnel, it would require a much more extensive dissection of the coronary there. That would be a difficult or not possible way to do it, because you'd have to either ligate the coronary and do a bypass. How old is this patient?
42 or so, yeah.
And this was a tunnel-like.
Yeah, that's what I assumed it was. But that makes a
LVOT
difference.
obstruction with a small aortic valve annulus as well.
So it was a combination of tunnel and small annulus.
Yep.
I would say an LV apical to aortic conduit would be the solution.
All right, so that's exactly what was done, and here's a MRI of the final result, which is quite impressive of a LV to apical or LV apical to descending aorta graft. And then here's some still pictures of this. The patient actually did quite well. Initially, she struggled in the hospital for a few days, and then subsequently, has recovered a lot of function. She had some issues and now follows up with Dr. Lin down in Irvine.
I just want to briefly mention about the technique of doing this. You could see by those rings, this was a 16 millimeter reinforced Gore-Tex graft, which for her size is adequate. The actual cross-sectional area is close to 2 square centimeters. And the way that this is done is by stenting the distal end of the 16 millimeter Gore-Tex graft. It makes it rigid. One can then thread a dilatation balloon into it so that you now have a nice smooth bullet-shaped device to put into the LV apex without going on bypass. And we sew a cuff of felt onto the end, which you can see there is sutured to the LV apex. And the actual LV, instead of cutting out a hole, which is hard to do off bypass, is just progressively dilated with a Hagar dilator, and then finally with a balloon. And then you switch from the one balloon, which is dilating it, to the balloon that's inside this graft, put it in, and with a balloon inflated, fix it to the LV apex. And then, before one has done that, the homograft is attached to the descending aorta. So this is done through 2 small incisions, one over the LV apex, one over the descending aorta. And then the 2 grafts are just sutured together. And you then have and that homograft, I believe, was a 18 or 20 homograft. So you have an off-part procedure. We've done this in old adults who've got porcelain aortas, and in people with renal failure, we don't want to put them on bypass, and it's a pretty good alternative. I think that, there's this feeling that LV apical to aortic is not such a great operation, because there was a while when it was being done kind of indiscriminately for subaortic stenosis and congenital aortic stenosis. And the grafts that were used were very large and required coring out a lot of muscle. But I think this is a good, viable alternative for selected patients.
Does the ventriculotomy, where the graft goes in, does that constrict down again? Does that collapse?
So far we haven't seen that, because that area is all stented. So we prepare it on the field, and we put a Palmaz stent inside the 16 millimeter graft.
Because those, especially when we put them close to the myocardium or through the myocardium, they sometimes will fracture and collapse on us. This one hasn't?
So far we haven't, but remember that you've got the rings of the Gore-Tex, which give it rigidity, because these grafts are quite rigid with the rings, and we leave all the rings on, and they just reinforce it with extra stent inside.
Good idea.
I guess that means if they were to collapse later, we could go in percutaneously.
Do it again.
Is there any problem in terms of dead space from the entire graft?
We were concerned about this. These patients have been placed on aspirin and Plavix initially, and then just aspirin. We haven't seen any thromboembolism from it.
I was thinking more of effectively lowering the ejection fraction.
Because it's rigid, I think you're adding to the end diastolic volume by that volume of blood, but during ejection, it's rigid, so it doesn't affect ejection fraction.
Where does the majority of the head and neck flow come from with these kind of grafts?
It comes from below. We've done echoes on these patients, and you'll see some blood going through the ascending aortic valve with no significant gradient across it, which shows you that you've relieved the gradient, and the blood goes up to the head vessels from below. And again, we haven't seen any neurologic issues from that. But there does continue to be flow through the narrowed aortic valve.
All right, so we have one last case. So this is a 34-year-old young lady who has severe manifestations of Turner syndrome. She'd undergone multiple plastic surgeries to address sinus issues, to address her ears. She also had a jaw implant to address her mandibular manifestations of the disease or of the syndrome. She works as a school teacher. She had a coarctation repair at age 11 years and became acutely short of breath after walking around the mall. She was admitted to an outside hospital and found to have mitral valve and tricuspid valve regurgitation that was graded by the outside hospital to be severe. She was diuresed a little bit and referred up here for evaluation. I'm actually going to show you some TE images because I think they're much more accessible for the images that we were able to obtain rather than TTE. So here you can actually see what we discovered was that the patient has a flail leaflet from likely a ruptured chordae. She has severe mitral valve regurgitation, and the atrial septum is bowing significantly. You can see here rightward, and you can also see how the atrial septum bows so much so that it's almost getting sucked into the tricuspid valve. The tricuspid valve regurgitation is not very well visualized on these echo images, but was of significant concern.
I think one other thing to point out is that she also has a pectus, some chest wall deformity that's significantly compressing that RV, that right side of the heart. You play some of those, actually, yeah, there you go.
We'll just play them all again. All right, so here's some additional views of the regurgitation, and then here's a 3D view of the mitral valve with prolapse of the A2 segment. The patient also had a cardiac MRI, and you can see that she's got a profoundly dilated left atrium that in the supine position after even significant diuresis, the patient still has layering of a pleural effusion on the right side. You can also see the regurgitant black blood up here in the left atrium from the prolapsing leaflet from the mitral valve. The patient was also found to have a recoarctation, and she also has sort of just a very hypoplastic transverse arch, and the recoarctation is quite narrow. So at this point, I'm going to throw it to the panel and ask, what's the best next course of action? Would you send her directly to surgery? Would you repair or replace both AV valves? Would you address the coarctation now or later? And then also throw into the mix that the patient wanted to finish the school year before having surgery or having anything sort of more invasive done because she didn't want to miss her teaching and her obligation to her students.
Lee, I'm sorry, I didn't understand. What was the mechanism or what's going on with the tricuspid valve? Why was it so regurgitant?
So, we weren't entirely sure if it was just from dilation of the RV from compression or from increased pressure from the mitral valve regurgitation that may have been a result of the obstruction from, the recoarctation. So we had a lot of theories, but we weren't sure what the best next course of action was.
Did she have a catheterization at all, or?
She did, which we'll get to in a moment as well. So the question would be, would we want to, catheterize her? One of the things that we theorized was maybe if we opened up the coarctation in the cath lab, would she be able to have an improvement with some diuresis of her regurgitation, maybe even prevent her from the need of having any tricuspid valve repair at that time as well. So we took her to the cath lab, and we started doing some assessments, and we were planning to address the coarctation first. We thought that might reduce the amount of time that the patient was on bypass. And one of the things that we discovered shortly after doing an injection in the ascending arch was a small chronic dissection just distal to the area of coarctation. Here are her pressures. Her end diastolic pressure in the LV was 25. Her wedge pressure was 25. Her RV EDP was 10, and her right atrial pressure was 10 as well. And then the gradient across the recoarctation was only about 10 millimeters of mercury, but we attribute that partly to being under anesthesia. Any thoughts from the panel about the next step? Would you go ahead and address the coarctation at this time? Are you concerned that maybe the length of the coarctation and the transverse arch was too long to address it from a cath-based intervention?
You had other evidence that the coarctation was more significant than 10 millimeters?
Right. Angiographic evidence of the coarctation. There's a focal coarctation there, but the other part of it, Al, that, I mean, this woman has wide open mitral regurgitation, low cardiac output state. So, frankly, and she's under anesthesia when we're doing these hemodynamics. So this is one of those where we thought that the coarctation should be addressed purely based on, angiographic evidence. But the problem is that the entire arch is narrowed as well. So just addressing the focal coarctation is really, I think, not a great variation in the long run.
All right, so we'll just continue with her course. So she underwent surgical repair of her coarctation of her mitral valve, end of her mitral valve, with a chordal extension, I believe, and the patient recovered very well from surgery. She, pepped up she was extubated on the first post-operative day. She was walking around. She was discharged within 4 days, and then she came back to clinic 2 weeks later, and unfortunately was in atrial flutter. Her ventricular function didn't take any hits from the abnormal rhythm, so the patient opted to be anticoagulated and was going to be brought in for cardioversion. However, on her own, she converted back to sinus rhythm and now has been doing well. She actually was very excited about a recent trip to Disneyland when we saw her.
So I just, from a surgical perspective, because we discussed this case quite a bit, Dr. Reeves ended up doing the surgery, if I'm correct. One of the issues was, and if you guys don't mind expanding on that, because if it comes up, is if you have to do an intracardiac repair through a median sternotomy, but you have complex arch issues as well as a descending aortic coarctation. Is that in this case it was not a problem because you were able to get to everything through an anterior approach. But one of the worries is that, you would not be able to completely address the arch and the distal coarctation through an anterior approach here. Can you tell us how you guys think about that?
Right. Well, I think
how low would it have to be for you to pump this and want something done?
usually if it's below the pulmonary veins, is on the CT scan, if you're looking where the coarctation can usually be fairly easily under, like I said, a short circulatory arrest, or if you want to do antegrade cerebral perfusion at the same time. The thing I was worried about most wasn't the coarctation; it was the size of this arch. I mean, she has a hypoplastic arch, and so you're going to leave her with a residual gradient once you fix this mitral valve. And so, essentially, this was just a large patch angioplasty, and so we cooled her down, did the entire arch, and then while we were warming, we did the mitral valve. So the bypass times and cross-clamp times were really short, and she did extremely well. But I think if you're opening the chest, what she needed for this, unless you could just do a short coarctation where you could put a stent in there, and we didn't need to do any type of arch repair. But in her, I thought that since she did have a hypoplastic arch, that it would benefit and do it all in one setting. But the coarctation itself, the way I look at it is when I'm looking at a CT scan, is kind of once it goes below the level of the pulmonary veins, it's difficult to get you from the front.
This is a combination of a coarctation recurrence as well as a hypoplastic arch. The one approach is the one that Brian has just described. The downside of that is the period of circulatory arrest and arch reconstruction, which in adults is associated with potential neurologic injury. The other alternatives would be to go through the front and do the mitral and possible tricuspid valve repairs and then put a graft from ascending aorta to descending aorta at the level of the diaphragm to bypass the coarctation site. And that would allow one to do the whole thing without circulatory arrest and do a combined procedure.
You know, the third option that was considered here, which we didn't go with, was the one that Lee showed earlier, which was the possibility of putting a stent graft from the, she has a bovine arch, so actually you can just go back to
that one?
She has a bovine arch there, so from just distal to the takeoff of the brachiocephalic and carotid, the left carotid, all the way down, cover the coarct, cover the dissection flap, and then possibly stent or balloon that focal coarctation if it can't be expanded. And that was just, it couldn't be gotten to from the front all at the same time.
And that was the thing, actually, when that wasn't actually like we talked about a chronic dissection. It was actually just where the patch was and never had any endothelialization, so you could still see the old Dacron patch there. So really, and there's nothing needed to be done at that portion of it. So that made things a little bit more straightforward as well.
Excellent. All right. Well, that concludes our case discussions. Thank you to the panel, and we'll invite Dr. Abel back up.